changes and there are changes in contracts, all of a sudden products may become non-available. That's what we noticed from this graph. What you see also is that the number of products included is more or less stable. However, there is a gradual increase in the number of reports, which means that the reports for an individual product are just increasing. This is the top 15 of products in that 3-year period, and in yellow I've indicated the products that have an oncology application. So there's metoxantrone, bleomycin, tablets for megastrol, doxorubicin and citarabine. You may have had the same situation here. What is interesting is that I put there also the companies that were involved and the number of reports and whether these were long-term non-availabilities or just short-term. And you see many of them were long-term and only a few were incidental. If they are incidental, like the bleomycin, with 83 reports, it means that there were repetitive reports in the 3 years with intervals with availability. But the long-term, it might be that the product was not available for, let's say, 2-3 months, and a 3-month period means that it will count as 12 reports. Then, of course, it's interesting, is this an equal distribution over the various therapeutic groups? And as you can see here, that is not. You see that group 13 and 13 are anti-infectives, and here you are, Professor Benny, that's our major problem, availability of anti-infective agents. This in this case also includes vaccines. Second on the graph is number 17, is our oncology drugs. They are usually used in an acute situation. You need them. There's many cases, not so many alternatives, and that is the second one. The third one is number 14. These are hormones, and these are the most important the 3 groups. So apparently, in some areas, it's more a problem than in other areas, and we do not have a clear explanation for that. So what are the consequences then? If we see here, as I said, 3 specific drugs that were not available for a long time, that was bleomycin. We just had a single supplier, he couldn't supply, and that was it. The megastrol acetate tablets for a certain strength, and then that was a worldwide problem, the liposomal doxorubicin, which was not available for a long time due to quality problems in the production site in the US that affected also many other products. So this is indicating the kind of problems that we may have. Some people say, well, it is particularly a problem of generic companies because of the high price pressure, they cannot deliver. And others say, well, it's because these are innovative companies. And as you can see here, it's not the case. It's about 50%, 50-50 generic companies of innovator companies. And what I've done for 3 years' time is, and I've indicated by color, to show that if these are always the same companies or that they change, it's a matter of courtesy that I left out the names of the companies. Well, you see, the yellow company is heading the competition for 3 years, all the time. The green is doing better. It's 2011, it's high. It's lower in 2012, and in 2013 it's gone. However, there may also be some intervention from our side, and I will come back to that later. So the important message is it's not always the same company, and it's about 50-50 innovator or non-innovator companies. So what are the consequences then for our daily business? Each week we have to find alternative suppliers. It takes a lot of time. All the time we have to make too many ad hoc decisions. We do not, as yet, even if we are struggling with this for 3 years, we do not, as yet we have not found a consistent policy that we can follow all the time. In Europe, we have the possibility to order drugs from other countries in Europe where they may have a license. That is relatively easy. However, our Ministry of Health is then imposing very strict rules for pharmacovigilance and other things, which we don't like. That's another burden upon the pharmacy. And sometimes I just panic that we get a message too late, we have scheduled patients, and we all of a sudden have a problem. So last year, we had a problem in BCG vaccine that is being used in bladder cancer, and we had really to convene together with the urologists to find a solution for that. If we have to buy a drug from another source, usually it's higher, the costs are higher, it can be 5 to 10 times higher. Another problem is that we have to communicate internally, because if we buy a product from abroad, it may not have a label in the language that everybody can read, so we have to provide additional labels. We have to communicate if it is a different strength. That is very risky, because the nurses usually think, well, I need 1 ampule of a drug, or I need 5 cc to administer to the patient, and if the strength is all of a sudden changed, they have to be aware that they need to make a different dilution, for instance. And overall, we worked out that this is costing us about half a full-time equivalent of pharmacy staff. And that's just one hospital. We made a survey in the Netherlands, and this is more or less the average for the larger hospitals in the Netherlands. So it's a huge waste of effort just because drugs are not there. They have been licensed, they have been researched, there have been a lot of investment being made, and all of a sudden companies just fail to deliver the drug. And then, well, you may have had the same experience. They phone us and they say, well, you have to make sure you have these drugs. It's your job to do that. And what I found out is that it is very important that in a very early phase, communicate the problem with the physicians and nursing staff and share the problem as quickly as possible. That was a message from Dr. Deutschmann from Bremen already more than 10 years ago when he wrote about this problem in the European Journal of Hospital Pharmacy. He found out that actually he was reporting the same kind of data each month in the Drug and Therapeutic Committee. So everybody in the hospital was aware of the huge amount of work that the pharmacy was investing in, let's say, trying to minimize the problem as much as possible. And everybody appreciated if the pharmacy came up with a solution. In my situation, sometimes they say, well, you should do a better job. I know, well, we will discuss this tomorrow, of course, in the workshop. So reputation damage is definitely done. You may not be able to read this in detail, that's not so important. I started with the website of the Drug Shortages Center from the American Society of Health System Pharmacists. Many countries have done the same thing now. It's in Spain, it's in the UK, and this is a copy from what is from the Royal Dutch Pharmaceutical Society that are monitoring now all the drug shortages and sometimes offering a solution. And we are involved in that now. So if they pick up a signal that the drug may become unavailable in the near future, they contact us and they say, well, how can we solve this? Is there an alternative, etc. Our Minister of Health was, we put the Minister of Health under pressure. And you can imagine the way I perceive this. I said, well, I think it's stupid. I really think it's stupid that we have a fantastic system for drug licensing and we don't watch the back door. How can that be? And actually, it's in the statutes of the European Union, in the drug law, that once you have a drug license in the European Union, you have the obligation to deliver. But the lawyers forgot something. There's no sanction. Can you imagine? So it's in the law, you have to deliver, but if you don't, there's no sanction. So nobody cares. Well, this is going to change now. So there was a Dutch National Working Party on drug shortages and everybody was involved in that, and they looked at the causes of the problem and they said, well, many cases it's just multifactorial. It's not just one single cause that you can point out. Sometimes are technical reasons, economical reasons, there can be change in legislation, regulatory interventions, quality issues, whatever. And people are operating to the best of their knowledge, but independently from each other. And if 2 or 3 parties making decisions, then all of a sudden it will be impossible to deliver a drug. To give you an example, in the European Union now, we started a system for certification of active pharmaceutical ingredients. Well, everybody knows that if we are going to maintain that system, many products will fail and we will not have them on the market. It's an administrative issue. It's not a direct threat to healthcare. It's not a direct quality issue. Just a lot of administration has to be done. You need committees, meetings, whatever, and it takes time to do that. So we warned the European Commission, don't implement that too fast because there will be you will creating actually drug shortages. So this is just a political reason then. And as I said, many of these factors may work in synergy, new rules, demanding higher quality, the cost is going up, the prices go down, there's no investment in quality, and producers just withdraw from the market. And all of day one, you have five producers, and independently from each other, they decide, well, we stop. And all of a sudden, you have nothing. That is what we have seen. So the vulnerability of the system is really terrible. So this working party came up with a couple of solutions, and they say, well, first of all, we need to have better insight in the problem. We need to stimulate the collaboration between private and public organizations, which actually means that the pharmaceutical companies and hospitals should collaborate more with each other. We should try to learn from experience how to tackle shortages, and that's why we have the workshop tomorrow. We should have insight in the production capacity on a national or the European level. Yeah, if one company cannot produce, but another company has spare capacity, can we move the production to another facility? And of course, the adaptation of laws and regulation have to be taken into consideration. The marketing authorization is duty to deliver, but then with sanctions. And we should allow, and we have them fortunately in Europe, many GMP-certified pharmacies to fulfill supply gaps. So if a company is not producing it, we can do it ourselves. We have a fully equipped GMP facility, and actually we are doing this at the moment. So if the company is not delivering, we do it. And, well, nobody can blame us, because for us, the patient is coming first. We've seen now that some governments have allowed forced marketing authorizations. So they take away the marketing authorization from company A that's not delivering and giving it to company B and say, well, please, will you be so kind to produce this? There is this problem with the importation of drugs from other countries. That should be relatively simple. However, there are loads of administrative burdens there, and that is also something I find very difficult to understand. I don't know how it is in the Gulf region, but in Europe, insurance companies sometimes have what is called a preference policy. So they single out one product that they say, well, this is the product that we prefer for our patients that are insured with our company because we have negotiated a very favorable rate. Well, usually that means that if it is a large insurance company, that other companies go out of business because, well, all the business is with one company. If that company then next fails to deliver the drug, again, nothing is there. So things that may sound sensible on first sight can be counterproductive in practice. And another recommendation is that the pharmaceutical industry has been asked to define a list of critical drugs with critical stock levels, and they should report that to the Ministry of Health. So it should be, shortages should be anticipated much earlier than in the beginning. So this was the inventory. Then, in July last year, 2014, was a second report from the Dutch government. It was actually commissioned to a consultancy company, Berenschot, and they were asked, can you tell us what has been the impact of all this? Because and the amazing thing actually was that it was very difficult to pin down specific health damage due to drug shortages. What does it mean? Well, there are two alternatives, I think, to explain this. One of is that the added value of medicines is relatively small. Without drugs or with drugs, it doesn't make big difference. That is one option. We really should take that in mind somewhere. However, I think it's because hospital pharmacists have done a bloody good job to find alternatives, to find the best solution in each case, so real patient damage is not being done. The organizational damage was considerable, both for the pharmacy, for doctors, nursing staff, patients, because patients don't like that, that they get different drugs, different labels they can't read, etc. And then risky situations could occur. But we were able to cope with that by changing the protocols. So what is then the Dutch Association of Hospital Pharmacists doing? They are making an inventory of the real damage that's being done. So we made a calculation model to figure out what are the financial damages. So how much time does it cost to do the market research to find an alternative? What is the difference in cost of the alternative? Are there additional shipping charges, extra labor involved, extra administrative cost, etc.? So they made a calculation sheet, and now we are filling that in for each occurrence of a drug shortage, and we try to come up now with a figure what the cost of all this is. And what we already know now, what we already know is that buying a somewhat more expensive drug is better than going for the cheapest alternative. So I want to make a daring suggestion, and that's what we try to do now. We try to change our purchase policy from discount buying to supply chain partnership, to discuss with companies, well, we are willing to pay a premium for the drug that you're supplying, but if you are supplying, and otherwise you have to pay a penalty. And based on such performance monitoring, we have shifted purchases from more reliable to more reliable suppliers. And at a cost, but with less problems we have in the pharmacy. So what's my take-home message? In many cases, not a single reason why a drug is not available. There are many, usually it's a combination of synergistic factors. The intuitive action, buy what you can, is actually increasing the problem. You're buying away the drugs from your colleagues. You need strategic actions at a higher level than a single hospital are needed. And we think that entering in a supply chain partnership with your critical suppliers may be a solution that is sustainable. And I thank you very much for your interest, and I have to thank my colleagues that have been collaborating with me on this project. Thank you very much.
Thank you so much. And we have about 8 minutes for discussion and question for the speakers, because they will not join us for the other discussion after lunch. So we have 8 minutes. I will open it for you. Okay, go ahead.
Thank you. I have two questions. One to the experience in educational hospital pharmacy in Saudi. Just I want you to highlight more about the payment of the pharmacist who is in direct patient care and training students and residencies on the practice field. Is it the same as, I mean, what we can see is the doctors, consultants, they are paid more when they are teaching. But we have this culture in within pharmacy, professional that's, I mean, no extra payment, but there is extra work. So that's one question.
Okay, let me answer this. There is no extra work. So the teaching and precepting the student will be part of your work. We will take much of your work and will give you the opportunity for teaching and precepting student, and the student will do some of your job. So that's one part of it. For the payment, usually it's part of the work, but there are other mechanisms for payment and depend on the school where the student coming from. Some school will provide payment and it will go to the pharmacist.
Thank you. The other question to Dr. Boni, the acute kidney injuries which happened in Scotland, is it post single prophylaxis dose of gentamicin? Is that cause the acute injury?
Yes, it's after one dose of gentamicin but in combination with flucloxacillin. So it's a combination that is attributed to the acute kidney injury at the moment that we've published on.
Thank you.
Thank you. Any other questions? I will be interested to hear some people talk about the drug shortages and our challenges here in the Gulf area, and especially in Oman. I don't know if Dr. Nasib or other people here. Oh, Dr. Saleh wanted to? So will be the next. Dr. Saleh and then you. If you want, if you can move to the mic, please.
Thank you, Chairman and speakers. I think the drug shortages in, first let me congratulate our colleagues from Netherlands that this is a very critical topic, is coming everywhere. And the Gulf region is really suffering. I monitor that when I was the Vice President for Saudi Drug Authority, because drug shortage came under responsibility because we get a lot of requests for non-registered or purchase from abroad, from unknown sites, or from brokers, and that is really a real problem. The major, responsibility, of course, as Professor mentioned in his first slides, that companies and mergers have played a major role, and then also the shift we see now from simple pharmaceutical products to more biological, new, high-cost product that would give more reward, and then we expect the problem to be worsening, and I don't see any solution in the future. Another issue with drug shortages in the Gulf also is our group purchasing program. Our group purchasing program, although it's been a very successful program, but unfortunately it's turned out to be a price war for companies. And you see a lot of companies left the market with a good product because the price. And this is so I would like to emphasize first we have to be reasonable when you ask for tax discounts, because even, I had one colleague in the Ministry of Health in one countries, he's even bargaining the companies after bidding. We just make it, he thinks he can save money, but in the long term, actually, he's losing money. And so this is something fundamental. We need to address it very seriously. There is one solution also I always recommend to colleagues that think about purchasing from two vendors. That means have two products of the same product in your pharmacies. Especially here, we remember we're talking about the annual purchase in the Gulf. So you purchase the whole year. So if you have two suppliers, better than one supplier, even of them, because it will lead to continuation of at least, that there's at least two companies always submitting. So because they know that two of them will get at least 50% of the bidding. So this is something we have to think about it seriously, although there are some financial rules preventing that, because the financial rules always buy the cheapest. But in the term of the medicine, we have, as people responsible for supplies, we have to change this rule. We have to put a limit for that and also encourage other companies. Of course, local manufacturing is an important encouragement, because if you can encourage your local producer for producing this shortage of medicines that you're facing, that also will continue supply. But they need commitment. You cannot ask them, you produce this product, and then later on you go and bidding them in the lowest price. They don't do that, because there's a lot of product. The margin of profit is very small. Thank you.
Thank you, Professor.
I like your comment very much, because this is also what we got as feedback from pharmaceutical companies that say, well, you as a client are not entering into a commitment to us, so why do you expect a commitment from our side? This is exactly the case, and that's what we try to change now with the supply chain partnership, so that we have a commitment towards each other.
Thank you. Last question.
Yeah, I would like to speak about the experience in Ministry of Health Oman. Now I came to understand that 99% of the products are facing shortage in your hospital. And another also fact I understand is that the client are blaming the pharmacy without knowing that this is maybe global shortage. Really, we are facing this problem in Ministry of Health due to global shortage, and but we have some measures we are taking. We are having a strategic reserve stock for the critical item. You said you have to identify the critical items. We have, this is helping us. And for other items which we have shortage, also we are just sharing your experience and practice. We are getting from abroad, from health attaché, UK, sometimes from India, but also we want to send here the message to the hospitals. Our colleague, the pharmacist, sometimes they are not complaining to higher authorities if items are discontinued without knowing, and now we are communicating with them to let them know what is the status of this. Thank you.
Thank you so much.
Maybe I think you are pointing out a very important problem, that most patients have no clue about this drug shortages problem. That was actually addressed by the Royal Dutch Pharmaceutical Society. They were actively looking for contact with journalists, and last year we had in some major national newspapers, we had large articles on this problem to make patients aware that availability of drugs is not just taken for granted. Sometimes it's really an effort to get the drug to the patient. So this is how we try to minimize reputation damage as much as is possible, because usually the patient just don't understand.
Thank you so much. The pharmacy practice session did not end yet, but we will have a break for 1 hour for lunch, and we will come back at 3 p.m. here. Thank you so much.
Dear speaker and guest, please join us for lunch break, which will be served on the Pearl Terrace. The event will be continued at 3 p.m. We will announce the poster winner at the end of this conference.
We will have two very important presentations. The first one about advancing your practice, the pharmacist, your role in hospitals and clinics, will be presented by Professor Christine Jolowski, and she's the Executive Director for the Applied and Experiential Education in the University of Minnesota, the College of Pharmacy, and also currently she's the President of American Society of Health System Pharmacists. So I welcome her to start presentation.
Thank you very much. And again, on behalf of the ASHP, it's a pleasure to be here representing some of the work that we're doing in the United States. My talk this afternoon will really focus more on how we're taking some of our practice and moving it into our ambulatory care settings. We've already spoken a lot today about our roles in hospitals, but one of the things that we're seeing is a shift of our patients into more practice and more care needed in that ambulatory care setting. And through ASHP, we're trying to work with our